Good morning, everyone. Welcome to our beautiful campus. For those of you who are on campus for the first time, please take time before you leave to walk around. It's a very beautiful campus. We're very proud. As you know, for those of you who have been here with us before, this is one of 4 campuses of Fairleigh Dickinson University. We have the Metropolitan Campus in Teaneck, our lovely campus in Vancouver, British Columbia, and of course our lovely campus also in Roxton, England. So I invite each of you, if you have a chance, to visit each of the 4 campuses. And when you walk there, tell them that the Dean from Civil College said, I'm welcome on all 4. We're pleased to have you for the Innovation Summit. As you know, Peter Drucker said years ago, innovate or die. And we certainly have embraced that spirit here in the U.S. No place has that spirit of innovate or die been alive and continues than in the healthcare area. Unless you've been living under a rock for the past 10 years, you know about healthcare, no matter which side of the spectrum you're on, be it liberal, be it conservative, be it profit, be it not-for-profit, be it a consumer, be it a provider. We're all faced with an enormous amount of information about healthcare. Some of us have to make decisions. But in today's age, with all the information we're faced with, we need those who help us make sense out of it. So we need decision makers and we need sense makers to help those of us who have to deal with the just enormous amount that comes our way. So welcome to Fairleigh Dickinson University. This Innovation Summit is an attempt to help us make sense out of all of that which we face. And to do that, we have a distinguished panel that will help us not only understand, but again, make sense. So again, welcome to Fairleigh Dickinson University, College at Florida. Now, it's my great pleasure to invite to the podium Fairleigh Dickinson University's Provost and Senior Vice President for Academic Affairs, Chris Capuano. Chris.
Thank you, Dean Moore. Good morning, everyone. It's great to see so many bright faces this early in the morning on yet another likely rainy day. President Adams was hoping to be here this morning, but unfortunately is recovering from some health care issues himself. And he regrets that he was under the weather and was not able to make it. But he did ask me to extend a very warm welcome to all of you and his best regards. This summit actually, I think, is especially important given the fact that Fairleigh Dickinson University is re-emerging in its leadership with respect to healthcare. Many of you probably know that we recently introduced the start of a new school of pharmacy, which we are pleased to be doing in partnership with Medco Health Solutions. We are very thankful to David Snow and his colleagues for making a very generous gift to the university, which resulted in the naming of the pharmacy school as the Medco School of Pharmacy, and we are scheduled to open next fall, fall of 2012, and we look forward to not only providing quality healthcare education, namely pharmacy education here at FDU, but also to becoming more involved with many of you as facilitators of reform with respect to the healthcare industry. Generally speaking, today's businesses have 2 primary goals in mind when providing healthcare benefits to their employees. The first is to provide quality healthcare, and the second, affordable healthcare. Now, while these 2 goals are often at odds, they can, in fact, be achieved simultaneously. One strategy to ensure quality and affordable health care is to manage the distribution and use of prescription drugs, as well as patient care information, more intelligently. Our first speaker this morning, Mr. David Snow, is a leader in doing just that and in promoting clinically driven pharmacy care. As CEO of Medco Health Solutions since 2003, Mr. Snow has led the world's most advanced pharmacy, delivering the safety of unparalleled dispensing accuracy and raising standards for clinical excellence. Moreover, Mr. Snow has helped Medco become an industry leader in areas ranging from personalized medicine to disease-specific therapy management for patients with chronic and complex diseases, patients who account for the vast majority of what we spend on health care in this country on an annual basis. Please join me in welcoming our first speaker, Mr. David Snow.
Thank you, and good morning, everybody. Let's see if this works. Works too fast. So let me introduce to you Medco. For those of you who don't know who we are, we're a $66 billion company. We're Fortune 34. Just so you know, when we took the company public in 2003, we were a $30 billion company. So we've grown to $66 billion in about 8 years. In the specialty space, we've grown from $1 billion to about $13 billion. We've grown from 12,000 employees to about 24,000 employees. And I would argue that the reason we've grown so well is the clinical innovations we've implemented since taking the company public in 2003. We like to call, the framework of our innovations making medicine smarter. And that doesn't mean we make medicine. We're not a manufacturer, but we make medicine smarter by leveraging a wired healthcare system, because pharmacy is the only part of the healthcare system that's wired today, using evidence-based protocols, using deeply trained pharmacists, and closing what we call gaps in care. If you look at the Medco strategy, it's really four-pronged. Basically, what we do is we manage smarter medicine. So we have half the Fortune 500 customers. We have half state governments as clients. We have federal government as clients. We manage their prescription benefits through formularies. We adjudicate the claims, whether they be retail or mail. We do all that. That's just, frankly, managing smarter medicine. Then we, in fact, deliver smarter medicine. Medco has about 4,000 pharmacists who do nothing but take care of patients and work with patients and doctors each and every day around the drug needs associated with their specific disease. At Medco, our pharmacists don't put pills in bottles because Medco's got proprietary innovations using robotics and technologies in our back-end dispensing facilities where humans don't touch the pills. Everything's done through robotics. It's like going to Disney World when you go to our back-end pharmacies. It's really fun. And at the end of the day, these innovations make dispensing medicine 23 times more safe than at retail pharmacy because we eliminate human error. So we have very focused care through what we call therapeutic resource centers, where our pharmacists do nothing but using a wired healthcare system, look at what a patient was supposed to be doing based upon what the doctor said the patient should do, looking what they're actually doing, identifying the gaps in care around their treatment protocol, closing those gaps in care. We also have the Medco Research Institute. Just in 2010, Medco released 10 different milestone academic write-ups, research papers that really are changing the way medicine's practiced, and we're very focused on pharmacogenomics, looking at the genetics of a person relative to the dispensing of medicine, a very powerful part of, I think, the healthcare future, and I believe pharmacogenomics and personalized medicine holds the promise for our country and the world, moving from shotgun medicine to precision medicine. I'll talk about that in a minute. And finally, we have a Medco Foundation. The Medco Foundation is simply available for those who can't afford meds on their own. We simply fund it. We get matching funds from others. We pay for meds for those who can't afford it. Theoretically, under healthcare reform, I won't need that foundation for that purpose anymore, because if there's one thing the healthcare reform bill tries to do, it tries to create access. Here's my issue, though, when you talk about healthcare reform. Healthcare reform is a three-legged stool. Everybody, I think, knows this. It's about access, cost, and quality. Sound reform deals with all three legs of the stool. My problem right now is we've got a bill that's all about access, It does very little around cost and quality, which means the bill today is hyperinflationary, and I believe you're seeing signs of that. There's an enormous opportunity to be more prudent, improve outcomes and lower cost, thereby allowing us to fund a new entitlement. Today, we are not funding that entitlement with savings. We're funding it with new dollars that we don't have as a society, and it's a problem. So the Medco innovations I want to talk about focus on improving quality. Outcomes go up, cost goes down. That's what Medco's all about. So let me explain what we're up to. Right now, today, in our country, 50% of the population has chronic or complex disease. When I started talking about this 5 years ago, the number was about 46%. Why has it grown to 50%? It's because of the aging of America, and it will continue. That 50% of the population consumes 96% of all the drug spend in this country. They consume 75% of all the medical dollars. And what's interesting is, if you look at the ICD-9 codes for all the chronic and complex diseases, almost 90% of the chronic and complex diseases use medication as the first line of defense, hence the opportunity that Medco seized. It's estimated that through the poor management of chronic and complex disease, each and every year in this country, we throw away $350 billion a year. We could get at that, improving outcomes at lower cost. That's just what we need to fill out the other two legs of the stool to afford access for those who are uninsured. And I'm pretty passionate about it. It's something I think we need to do. So let me explain in a little more detail how we're throwing that money away. There are two key areas. Number one, patient adherence. Patients don't do what the doc tells them to do. It's amazing. The data is crystal clear. When you have a chronic or complex disease, the patient's attrition rate from the doctor treatment plan within a year is 65%. They stop doing what the doc tells them to do. So if you're a diabetic or a hypertensive and you stop doing the lifelong treatment you need to do with that chronic problem, it's not a matter of whether, it's a matter of when you will end up becoming unstable, ending up in the emergency room, ending up in the hospital, having a really poor quality of life with really bad outcomes, and driving the cost of the system through the roof. The number two thing, and this is one that more people don't realize goes on, is it's incredibly hard for docs to keep up with the rapidly growing knowledge domains in medicine. The discoveries are actually accelerating in the practice of medicine. Physicians can't keep up with it. And docs deviating from current practice protocol, 33% of the time they're deviating from the most current evidence-based protocol around the disease, which leads not only to additional cost in the system, but it also is a driver of the $200 billion additional problem we have around medical malpractice in this country. If we could practice to protocol, keep the protocols current, we could keep physicians out of a lot of trouble when it comes to medical malpractice and wring another $200 billion on top of the $350 billion out of the system. So let me just talk about these two things. C. Everett Koop said it well. Drugs don't work in patients who don't take them. And the data is really clear. This is an A.T. Kearney study. There have been others like it. If you look at major treatment areas like depression, within 12 months, 90% of patients stop doing what the doctor says they should do. Hypertension, 65% stop doing what the doctor told them to do within a year. In the case of diabetes, 62% stop doing what the doctor told them to do within a year. That is a massive, massive problem. You're spending all this money as an employer or a payer on drugs that will work, but they're sitting in the medicine cabinet, they're not being taken, and the patient still ends up in the hospital in the emergency room. We're paying the bills twice. If you look at the number two issue, if you look at the problems with physicians keeping up with evidence-based protocols, it's interesting. If you look backward in time, from the time landmark evidence is developed, it takes on average today 17 years before it becomes standard of practice. 17 years, and frankly that number's growing. And the reason it's growing is the knowledge domains are getting deeper faster. So right now today, for a physician to stay current, they have to read 75 primary studies and 11 meta-analyses daily to stay current. And that assumes a physician has the capacity to remember everything they read. They don't. It's fundamentally impossible. So, this just begs the need for evidence-based protocols that stay current for the doc. Here's kind of, my father's a physician. I understand docs hate to talk about evidence-based protocols because they call it cookbook medicine, which, really rubs them the wrong way. But my feeling is a real protocol is a decision tree. If this, then this. And it can be as intricate as you want it to be. And if it's in your head, it can be put into a perk chart that allows us to systematize what we do just the way pilots do on airplanes with their checklists. Atul Gawande talked about this. You have to keep these things in a checklist format or you will make mistakes. Human error will run rampant, and it does in healthcare. So here's what's going on in medicine. So many new technologies, so many new discoveries, new sciences are being developed that lend themselves to the body of knowledge a physician has to remember in order to make a clinical decision. Let's just isolate one. Since the unraveling of the human genome in 2000, genomic data and personalized pharmacy specifically, what's gone on in that space? Put yourself in a physician's position. So from 2000 to 2007, you can see the rate of growth, both in terms of the diseases and the genes that are related to those diseases that you should know something about in order to diagnose a patient uniquely. In 2008, we added 42 new diseases and 364 more genes tied to discovery. This is incredible. And by the way, these genes have these names. And the docs who try to remember any of this transpose those letters all the time. They order the wrong tests for the wrong reason and get the wrong results and draw the wrong conclusions all the time because they're trying to remember this. It's humanly impossible. So the Institute of Medicine put out a study recently that's kind of interesting, just looking at the explosion in the genetic area, the discovery since the unraveling of the human genome. And they ramped up the knowledge domains through 2020 just to that science and the ability of a physician or a human being. How many facts can a human being consider to make a decision? The max is 5. The max is 5, and just this new science alone creates far too many facts for a physician to remember. By the way, let's assume physicians are smarter than the average human, so let's assume they can remember 7 or 8 facts. It's still a problem, and this is just one part of the total constellation of things that are evolving very rapidly that physicians need to remember. We're entering a new science after genetics that's called epigenetics. And these are additional switches that turn a gene on and off on top of the gene. And this science is exploding as well, and it's just hopeless to think a physician can remember this, even if they specialize. It's impossible. So, what this really defines is a need for a wired healthcare system that allows you to know around all the caregivers, it's patient-centric, what the patient's doing, are they compliant, are they following current treatment protocol, and if they're not, pick up the phone, intervene. Having this kind of capability is essential, I think, if you ever want to see accountable care take off. I used to work at U.S. Healthcare a long time ago. I know some people in the room did as well. We used to capitate primary care docs. And it didn't work because we put the doctors at risk. The doctors would tell a patient what to do. The patient would go home, not do what the doc told them to do, end up in the emergency room. The doc got the bill and went bankrupt because they couldn't intervene when it was really critical in that ambulatory setting. They had no radar, no visibility to what that patient was actually doing post-office visit. So wired healthcare is going to be essential to our future. Medco has levered that today. Remember, the only part of healthcare that's wired today is pharmacy. No matter where you go in the country, no matter where you get your drugs, we know the full constellation when you're a Medco member. So does CVS Caremark, so does Express Scripts. All of the PBMs have wired healthcare on the drug side. We've taken that knowledge and we've basically moved to levering that wired system so that we know when a patient's doing what the doc said because we can see refill rates, and we know what the doc prescribed against evidence-based protocol because we can see what's being filled and we see it real time. What we do is it populates an evidence-based protocol. We use the national standards for diabetes, for hypertension, and the treatment protocol, and we measure gaps in care. And our pharmacist's job is to improve total compliance rates on the part of patients relative to the treatment plan the doc prescribes. And we actually measure that and make guarantees to our clients. And the power of this is compelling. This is real data. This is just one example. The x-axis here is compliance rate. The further out you go, the more compliant the patient was with the physician's treatment plan. The y-axis is dollars per member per year. And you can see the correlation between compliance and reduced cost per patient per year with diabetes. We literally cut it in half when we can get the compliance rate up over 80%. You see the drug cost, which is the yellow, goes up a bit, and that's intuitive because you're actually compliant with the drugs, but total healthcare costs come down. This is applicable for literally every major chronic and complex disease, and the returns on that investment are powerful. So if you link up that visibility to the medical home, the accountable care organization, you link that together, you have some real healthcare reform going on that holds the promise of improving outcomes and reducing costs. This is moving on. On top of this, we have protocols. We're the only pharmacy that does this, that keeps track of the pharmacogenomics, which is the newer science relative to treating patients at a personal level tied to your unique ability to metabolize a drug. This is very powerful stuff. Right now, 75% of all drugs dispensed in this country have a warning on the drug box that talks about the pharmacogenetic implications of the drug, meaning most drugs you should know something about the unique patient's genes before you dispense. And here's why. This is just a couple of examples. These conditions, let's take Alzheimer's. There are 2 drugs out there that are popularly used to slow down the rate of progression with Alzheimer's, but they only work in 30% of the patient populations out there, and it's genetically related. We know this. But no one's doing genetic tests. In fact, those genetic tests aren't even paid for if they're done. So what happens is everybody's getting prescribed one of those 2 drugs. They're very expensive. So the U.S. drug spend on those 2 drugs is about $1.5 billion, but it's only working 30% of the time, so we're throwing away $1.1 billion. That's how this works. You go down these small number of categories, and you can see we're throwing away $17.5 billion tied to prescribing to patients who these drugs don't work for, period. They will not work because of their genetics. And that's just the tip of the iceberg, because underneath that, if the drugs aren't working, the patient continues to get sicker, and we're spending money in the emergency room, in the hospital, in the doc's office, and all kinds of other diagnostic tests because we didn't bother doing the genetic test in the first place. So we're very focused on this, and our clients today have us call the doc, get the genetic test for the most important drugs to make sure we are matching up that person's genotype with the drugs, either the quantity or the type of drug dispensed to that patient. Here's a couple of examples of what we're doing in the pharmacogenomic area, and this is primarily out of the Medco Research Institute. We used a retrospective database. We have one of the largest drug databases in the world right now on 66 million people. And we basically went back because there was a scientist who theorized that patients who take an antidepressant with the drug tamoxifen are much more likely to get recurrent breast cancer than those who just take the tamoxifen. So let me take a pause for a minute. How many of you know the drug tamoxifen? Okay, about half of you. The drug tamoxifen is the most commonly used drug to prevent the recurrence of breast cancer. It's a known fact that 10% of women cannot metabolize tamoxifen because they don't have the right gene. They don't create the enzyme needed to break down and activate the tamoxifen into its active state. It turns out that when you're diagnosed with breast cancer, you're often depressed about it, and you ask the doc for an antidepressant. It turns out the SSRI category of antidepressants uses the same enzyme that tamoxifen needs to activate. And the SSRI shuts off the gene making it impossible for you to metabolize the more important drug, tamoxifen. And we found that patients had recurrent breast cancer 60% more often if, in fact, they took that combination than tamoxifen alone, when they had the right genes in the first place. And by the way, just on tamoxifen alone, it's been known for 10 years that 10% of the population in this country cannot metabolize that drug, and there are many, many other choices to prevent the recurrence of breast cancer. The test has been available, and it's very cheap to determine if you're one of those people who can't metabolize that drug. It's been available for 7 years. How many docs out of 100 docs do you think actually does a genetic test before they put a woman on tamoxifen? What would be your guess? 1 in 100 today, 7 years later. And I argue it'll be 17 years before it's over 50%. You know, it's very powerful. We did this study. The FDA grabbed onto it. They put a black box warning on to make sure docs knew not to prescribe the antidepressant with that drug, because it really does shut off your ability to make that drug work. By the way, even with a black box warning, it's probably going to be 17 years before the majority of docs do the genetic test or stop doing that combination. Here's another big study we did. This was huge, very big deal. We looked at our database again, did a retrospective analysis, and in this case it was the drug Plavix. Plavix is the #3 drug in the world. It's used to prevent clotting. It's very frequently used. And it turns out that Plavix is activated by a specific gene type. And most people have it. There are some who don't. You need to be aware of it. There's a black box warning on the label now because of it, because of Medco research. But there was another issue, because proton pump inhibitors, heartburn meds like Nexium, as an example, also use the same gene. And the proton pump inhibitors turn off your ability to metabolize the Plavix and make it active. So out of a almost 17,000 person study retrospectively, what we found is those people who took a PPI with their Plavix had a 50% increased risk of a cardiovascular event like a stroke and a 74% increased risk of a heart attack, because it shut the drug off. We published this in November of 2008. The FDA put an early warning out in about February of 2009. The FDA put a black box warning label on this in May of 2009. It was widely covered in all the medical literature across the globe. The green line is dispensing at mail with evidence-based protocols with this specific fact in there. The red line is what goes on at retail. And by the way, we alert retail when that combination occurs, but the pharmacist can override in retail. I can control my pharmacist in my mail operation. From the time we made the discovery, we reduced that combination by 33%, and I know we've saved a lot of lives because of it. It actually increased 14% at retail over that same period of time. Again, this happens all the time, and people don't know it. You can't expect a smart consumer to know this stuff. There's just way too much to know. We need to retool the way we organize our systems so that these things are known by the person you trust, your physician, at the time of prescription. That needs to happen, or else these kinds of, and by the way, anyone who prescribes this combination now, and it'll take 17 years for these to come down where they belong, where you don't do this in combination, malpractice suit, you pick up the money, you don't even go to court. It's a given. Same's true with tamoxifen. You give a woman a tamoxifen and she's one of those people who can't metabolize that drug. All you have to do is, if you're a smart lawyer, do a genetic test, see if you ever had a chance for that tamoxifen. If you don't and you got recurrent breast cancer that's metastatic, you're paying. It's done. But if the doc had done what the science is telling him to do now, that would be eliminated. One more big study, this was prospective. In the case of warfarin, I don't know if you know the drug warfarin. It's the most dangerous drug we dispense. It's basically rat poison, but it's a terrific blood thinner. And that's how it kills the rats, by the way. It thins their blood out and they bleed to death. Coumadin, too. It's Coumadin, warfarin. And here are the facts about Coumadin. It takes 6 months to get a patient to a safe dose. And the way it works is the doc starts you on 5 milligrams. You have to go to the office every 3 days, titrate your blood, see how thick or thin it is, adjust the dose. But 6 months into it, you get to the right dose. But in that 6 months, 25% of patients are admitted to the hospital with a severe clot or bleed that's life-threatening or creates death because you didn't get the dose right. The reason you don't get the dose right is Coumadin or warfarin is metabolized by one specific enzyme in your liver, and we all manufacture different amounts of the enzyme. So we could be a fast metabolizer, a normal metabolizer, or a slow metabolizer, and it's fundamentally important when you're talking about a dangerous drug like this. So we had a theory. We did a prospective study with the Mayo Clinic. We felt we could both reduce the time it took to get a patient on a safe dose of the drug, and we could in fact reduce dramatically the hospitalization rate if we did a genetic test up front to determine whether you're a slow, fast, or neutral metabolizer of the drug. So long story short, we did the study. We found that when we did a genetic test, we changed the starting dose 66% of the time from the old way. We reduced the time it took to get to a safe dose to less than 3 months from 6 months, and we reduced inpatient hospital admissions tied to bleeds and clots by over 30%, 31%. And by the way, I think we could have reduced it by 50% if docs who were doing elective surgery did the genetic test when they knew they were going to put the person on Coumadin anyway. They should have done the genetic test before the elective surgery, because what we do is we see the first dose of Coumadin or warfarin go out, and we call the doc, get the genetic test, get it to the lab, get the results back, then make the change. That takes about 40 days. In those 40 days, some of the people who are the very slow metabolizers bled out before we could get back to them. But if you had known right up front and had the right dose to start with, that never would have happened. You take those patients out, you're over 50% reduction. This is the kind of stuff we need to do. And by the way, there was a black box warning on Coumadin before we ever started this study. It was an amazing coverage. It was in the Wall Street Journal, New York Times, all the medical literature. And so when we started calling doctors to get the genetic test after all this big hoopla, what happened? Out of 1,000 doctors, how many docs had ever even heard of the genetic test when we were trying to get this study done? 3 out of 1,000. So again, it's a proof point that the docs can't keep up with the science, and they admit it. They admit it. They're not even trained pharmacogenomics and genetics in med school right now. So it's something that's a huge opportunity. So let me just kind of summarize the Medco strategy. When you do a clinical trial, basically what happens is you control the population who's taking the drug to get the data to submit to the FDA to get approval. In the case of Zocor, that's what this is, it took about 5.4 years to get the data, and the patients stayed on the treatment protocol for the entire time. The vast majority stayed on it. You submit the data to the FDA and show that over a long period of time, that cholesterol-lowering drug reduces cardiovascular events. So but then what happens is you go to the real world, you should get the same kind of return that you got in the data that the FDA saw, but you don't because of this non-adherence issue I talked about. So our therapeutic resource centers and what our pharmacists are doing are designed to elevate the game, to get it back to the data levels the clinical trial showed was worth it. Frankly, if the FDA saw the real world data, they never would have approved Zocor in the first place, because the non-compliance means it's useless. So then what we do with pharmacogenomics is we say, well, wait a minute. Even in that clinical trial, there were patients who didn't have the right genetics to respond to that drug. What if you knew that and you took them out of the population? You're going to have better results than the original clinical trial. That's a huge opportunity, and it's across literally every drug in the spectrum. Almost all drugs have some kind of pharmacogenomic implication. It's a huge opportunity. And I'm going to run out of time, but I do want to just tell you one thing. We've now pushed this knowledge that our pharmacists have, we've pushed it to our customers, our patients. So our patients, in a layperson language, can go online under their secure password and ID and see their own evidence-based protocols. They can see all the information in a layperson's language. They can see videos about adherence and the drugs and how they work and why they're important and what you should talk to your doctor about. And if the patient still needs help and doesn't understand, basically they can click a button saying, I want to talk to a specialist pharmacist. They put in the phone number that they want our pharmacist who specializes in their disease to call them out, and in 60 seconds, they're on the phone with a specialist pharmacist. On top of that now, what we've also built is the ability to do over-the-counter drugs, because by the way, there are huge pharmacogenomic consequences in the over-the-counter drug space. Perfect example is PPIs are available over-the-counter now. So if you're on Plavix, you can go to your neighborhood drugstore and over-the-counter get a heartburn med and actually increase your risk 74% of a heart attack and not know it, because there's no alerting system, there's no safety net for the over-the-counter drugs. We've built that. We have an over-the-counter drug capability we dispense, and basically what we've done is we've built software algorithms to alert the patient when they're buying the drugs online that they have a serious danger here, and it's amazing. They see this alert, they see what's wrong, they pull the drugs right out of their shopping cart. So right now we've got over 30 billion different combinations of drugs that are online and available to the consumer real time. Even non-Medco members, we've built the capability for them to put their own drugs in and find out their own information about this. This is the online experience for over-the-counter drugs. Real quickly, what you do is this typical online experience, you buy what you would have bought in the retail store, you push the checkout button, a calculator comes up, bumps up what you're buying in your shopping cart against all the drugs we know you're taking. And then basically what happens is you get the alerts, it tells you what the issue is, and you have to either talk to your doc or put it back on the shelf, because we offer other alternatives to what you're supposed to do. So it's about taking the knowledge we have today, turning it into a system that supports the practicing clinician and the patient. And we can save far more money than anyone's ever talked about in the current healthcare reform debate so far when they talk about insurance reform. And with that, I am done. And I don't know if I ran out of time, but...
Perfect timing.
Okay. All right.
Thank you, Dave. Eye-opening and troubling.
It is troubling.
And I'm sure we have a bunch of questions. So we'll leave it open for questions for now. As most of you folks know, we try to keep the questions short so we can get as many in as possible. So raise your hand, wait for the mic, and we'll come to you.
There's a bunch of them. Any over there? Right.
I'm a recipient of one of your Medco pharmaceutical encounters, and they're wonderful. I just want to compliment you.
Thank you. I appreciate that.
I have had diabetes for over 60 years, type 1, and I've done quite well. But I was, thrilled with the encounter with the representative, pharmacist. Anyway, one question I have is, whose job is it to educate the physicians?
That's a really good question. If any of you who know physicians, my father's one, and I used to run hospitals, so I know the physician personality. They don't like to be told about things because they know, and you shouldn't have to tell them. But I can tell you that I think it takes a village. I think healthcare is at a point now where it starts in med school, but it can't stop in med school, because we're even seeing in the data, physicians coming directly out of med school are much more current to evidence-based protocol than those who've been out in practice for 30 years. They get behind, and I showed you why. Keeping up with the knowledge and running a practice is virtually impossible. So med schools need to train physicians clinically, and I also believe med schools need to start training physicians from a business perspective, because they are really oblivious to the cost consequences of the decisions they make. But after that, I do think you need a wired technology that allows them to keep current without reading every single one of the articles that's ever published, because it's humanly impossible. So it's an ongoing thing. Medicine's gotten so large you cannot memorize any longer. You just can't. The brain is incapable of memorizing everything you need to memorize. You need a checklist. And Atul Gawande wrote about this in great detail, and I'm a big believer in it. I prefer to give it a more sophisticated name, evidence-based protocols, but checklist is fine. It really does work so long as the checklist remains current and someone's responsible for keeping that protocol up to date, because the science is changing daily. I think it starts with an acknowledgement that this is needed, and then a real push to wire the system so that You have a protocol, and you get the real-time data to populate the protocol, and that's a great way to stay educated while still practicing medicine, because you can't go back to med school to keep updated all the time. It's impossible.
One of the challenges for physicians dealing with chronic illness is dealing with comorbidities and managing the process. Is the testing that you're talking about a one-shot generic test that, as the doc is changing meds, that they can refer to that profile, or they have to keep repeating multiple genetic tests, which gets complicated and costly?
Genes don't change. So when you do a genetic test for a specific gene, it never changes and the information's valid. It turns out there are 5 specific genes that if you actually know the results from those 5, you will know how a patient will respond to about 70% of all the meds dispensed, because certain genes are responsible for activating and metabolizing a lot of the drugs we dispense today. So we're even looking at a 5-gene panel right up front, so that you have all the information, and as all these new discoveries come about, or you change regimen and you want to treat the patient for another disease, these genetic data are still valuable. You just need the algorithms to tell you about that as we discover them on a go-forward basis. So, in our Diabetic Therapeutic Resource Center, most diabetics, we have 5 million complex diabetics with multiple comorbidities. Our protocols deal with all those comorbidities, and at the drug level, you still need to know genetically, is this going to work for this patient? And so we capture that, we preserve that, and any future drug prescribed will bump up against the knowledge we already have about the genes and alert the physician real time. So I think that's the way we need to go. And these genetic tests right now anyway are drug specific. They're not, it doesn't matter the disease, it's about what is the activator of the drug regardless of disease when it comes to gene testing. Over here, okay.
The year is 2020. What do you see in terms of changes from now to then?
God, I can't even see past 2012. 2012, everyone thinks, hey, we've got healthcare reform. Frankly, the healthcare reform bill is one of the most difficult things as a CEO to respond to I've ever seen, because it was promulgated in 2010, but nothing's effective till 2014. And everyone's putzing around, they're not writing the rules, so what am I building to? What am I supposed to be, what does this thing look like before I spend millions of dollars for exchanges or the MLR rules or all the other things that are still being written? So on top of that, what happens in 2012? Well, you've got the super committee that's probably going to take another big hack out of healthcare because it's such a big part of the federal budget. What is that going to change? Then you've got the Supreme Court looking at exchanges and the mandate. Is that valid or isn't it? If you can't mandate, the exchanges die because you get such adverse selections they fall apart. So that's a really important decision that comes before and then you have the election. And honestly, whoever takes over the Senate and the White House could have an enormous, influence on what healthcare reform really looks like. So, 2020, my God, there's one constant that I think is going to stay true, given the situation our country's in. We must get better, faster, cheaper. So, if the things you do today make you better, faster, cheaper, it makes you more relevant for whatever comes down the pike. So that's how I'm investing our money. Better, faster, cheaper, and I don't know if exchanges will be around in 2020. I don't know if we'll have a single payer system. Even in a single payer system, the government uses the private sector to administer their plan. Again, to be relevant in that world, better, faster, cheaper. That's my best advice.
You mentioned that capitation had not been successful for chronic care management. It seems like in theory, it's an appropriate model for managing chronic care. And I was wondering what you thought needs to be different in the current system in order to make, say, a per member per month model for chronic care to be successful.
Capitation at a primary care gatekeeper level leaves a lot to be desired. I honestly believe if you've got a chronic disease and that is your dominant issue, you're often very well served, better served by having a specialist. And I think accountable care is much more of a group practice thing than a primary care gatekeeper thing. So the medical home to me is more like that old gatekeeper model I played with. Accountable care has much more potential. But here's the big issue. I don't know how many of you are following the accountable care regs. They're a disaster right now. It's not going to happen. And there are two fundamental problems. Number one, they want docs to take risk in big groups, but they refuse to assign the patient to the group. So they make you accountable but not responsible. The patient doesn't even know they're assigned to your group, and if you go over budget, the group gets the bill, but they're not in charge. It's not going to happen. I was just with the CEO of Cleveland Clinic last week, who's the best prepared of anybody to be in an accountable care organization, and until these regs change, they will not do it, period. Anyone who does it is going to be subsidized just to make it work, but you cannot put people at risk without making them responsible and having the patient know, who they report to. It just doesn't work. The other thing is, and this is what you would expect of government, there's supposed to be a risk reward associated with taking on a patient population and being responsible for a better outcome. And it's supposed to be a combination of carrot and stick, but typical government incentive model, it's 90–95% stick and maybe 5 to 10% carrot. And most docs look at the incentive model and say, hey, fee for service is safer, I'm not moving. So I think that accountable care, levering a wired healthcare system with the right incentives and the right accountabilities has a very good chance of working, because you have the visibility to what the patient does in between office visits, and you're motivated when you see something wrong to pick up the phone and call the patient and ask them what they're doing. Right now, there's no reward for a doc to do that. So I'm hopeful we could get there, but we have a long way to go against the reg that's out there right now.
I didn't understand completely how the pharmacist can help with compliance. If a doctor gives you a prescription with 3 refills and you get the 3, but he wants you to come back and you don't go back, what can the pharmacist do?
Well, what we do is, so let's say you have a chronic disease, and let's say you have high cholesterol, something simple, and you're supposed to take your Lipitor every day. When you do a refill, we can see whether you've done it. So let's say we dispensed you a 30-day supply, and 45 days into it, you haven't gone back for your next refill. Either your doc said, I want you off, and we don't know it, which isn't typically the case in high cholesterol, or you're not taking the meds the way your doc told you to. So our pharmacist actually will call you and ask you, did something change? Why is it that you're so late refilling your med? And you'd be amazed at some of the answers we get. It's amazing, the misunderstandings. It's incredible. It's mind-blowing. In asthma, you typically have an emergency inhaler and you have a maintenance inhaler. Patients all the time don't understand the difference, and they end up, because they can actually feel the emergency inhaler, they take the emergency inhaler every day and they don't touch the maintenance med, which is really dangerous, and it gets you all hepped up, and then you see them going to a doc for a sleeping pill because they're buzzing when they go to bed at night. And they just mixed up the drugs. They don't understand the difference between emergency and maintenance, and we have to straighten them out, get them on the right path, cancel the sleeping med, get that whole thing lined up. It happens all the time. Patients sometimes economically can't afford to take them every day, so they decide to do it every other day. Wouldn't that work just great? And the answer in most drugs is no. And so we just have to re-educate, and we do it because of these alerts when we see you're non-compliant. Another thing that's very common is a doctor will prescribe a set of drugs for your disease that's newly diagnosed, and then you go to the drugstore and you don't fill all the prescriptions. You fill 2 out of the 5. That'll show up as the doc not following protocol. It's really not the doc. It's you not doing the regimen the way you're supposed to. And in that case, we will start with you, and then we'll talk to the doctor, and we'll get it straightened out, and we'll re-educate. And what's really great is we look back and we watch a patient after our pharmacist has had that conversation and really taught them about why they're doing what they're doing and how dangerous it is not to do what you're supposed to do. The recidivism relative to patients stopping again is very low. The patients, once they're properly educated with the right reinforcement, later on in the treatment process, it's very effective. They stay on the wagon once you re-educate, and that's what we do. And I'd like to see the doc's offices doing it too, and what my vision would be, what my pharmacists see and what I'm now pushing to the member, I also want to push to that doc's office who's taking risk, so they too can manage risk better, because they can see what their patient's doing in between office visits. That's what makes it powerful and makes everyone connected.
Okay, thank you very much, Dave Snow.
Thank you.